Next generation presentation, Dr. Sonalika on orbital apex syndrome, clinico etiological profile, diagnostic challenges and outcomes.
Good afternoon, everyone. I'll be talking about our study title, Orbital Apex Syndrome, the clinico etiological profile, diagnostic challenges and outcomes. Orbital apex syndrome, it refers to a constellation of symptoms and signs which results from the involvement of various structures in the region of orbital apex by a disease process. And it is characterized by ophthalmoplegia, proptosis and ptosis from palsy of cranial nerves 3rd, 4th and 6th, hypoesthesia of ipsilateral forehead, upper eyelid and cornea by involvement of the ophthalmic division of the trigeminal nerve, and eventual visual deficit from optic neuropathy. So the objective of my study was to report the clinical profile, diagnostic challenges and outcomes in cases of orbital apex syndrome presenting to neuro-ophthalmologists or neurologists. So we did a retrospective review of records of patients with neuroimaging proven orbital apex syndrome seen from October 1, 2018 to June 30, 2022. We documented the age and gender, the clinical presentation, visual acuity, visual fields, radiological changes, optic disc morphology, and the treatment given at presentation and follow-up. So the MRI brain findings were characterized as following, suggestive of either a granulomatous lesion, a fungal etiology, IgG4 disease, MOG optic neuritis, carotid cavernous fistula or cavernous sinus thrombosis, cysticercosis, neoplasm, non-specific inflammation, and if there was no abnormality recorded. So the patients underwent MAN2 test, chest X-ray, serum ACE levels, IgG4 levels in blood, ANA profile with ANCA and endoscopy, biopsy, thyroid profile and CSF analysis. And a total of 52 patients with orbital apex syndrome were identified with a female preponderance. The median age was 46.5 years and the median follow-up duration was 3.5 months. And 22 patients had hypertension as the associated comorbidity, 20 patients with diabetes mellitus, and 10 patients had a history of COVID infection, and 2 patients had dyslipidemia, and 2 underwent ENT procedures. And the presenting complaints, the major presenting complaint was blurred vision in 40 patients, periocular pain in 30 patients, ptosis in 30 patients, diplopia in 16 patients, and proptosis in 14 patients. And 47 out of those 52 patients had extraocular muscle involvement with diffuse ophthalmoplegia as the most common presentation, followed by 3rd cranial nerve palsy, involvement of both 3rd and 6th cranial nerve in 7 patients, and involvement of only the 6th cranial nerve in 3 patients, and none had isolated 4th cranial nerve involvement. So at presentation, 29 out of those 52 patients had best corrected visual acuity of less than 20 by 200, and 23 patients had best corrected visual acuity of more than 20 by 200 at presentation. And out of the 20 patients with follow-up visit at 3 months, 13 patients had best corrected visual acuity of less than 20 by 200. And the optic disc morphology ranged from a normal fundus, which was seen in 30 patients, and diffuse disc edema in 3 patients, and optic atrophy in 17 patients. The mean deviation on Humphrey visual fields, which was possible for 21 patients, was minus 11.18 decibels in the affected eye. And out of those who had a follow-up, the mean deviation improved to minus 4.4 decibel at last follow-up. And they underwent the investigations as I mentioned before, and majority of the patients had an abnormal MAN2 test, which was recorded as abnormal in 9.6% patients, and an abnormal endoscopy in 9.6% patients respectively. Then the MRI findings in patients more than 40 years of age was, the leading cause was a non-specific inflammation, which was followed by fungal etiology. And in less than 40 years of age, the leading cause was again non-specific inflammation followed by granulomatous etiology. These are some of the representative lesions on MRI which we found in our patients. And 33% of the patients received oral steroids and 25% patients received IVMP, and others received antibiotics or antifungals according to the etiology. So there was a predominance of orbital apex syndrome among females, and the presenting complaints were diminution of vision in 76.9% patients, and followed by diplopia, periocular pain, ptosis, and proptosis, and majority of the patients presented with extraocular muscle restriction. And diffuse ophthalmoplegia was the commonest form of motility restriction, and visual acuity was worse than 2200 in 55.76% patients. And MRI findings revealed non-specific inflammation and fungal etiology as the leading causes of orbital apex syndrome in patients aged 40 years and above, and granulomatous etiology and non-specific inflammation in patients less than 40 years. Thank you.
So in post-COVID, we had more of fungal problems. Were those cases also included in this case series?
Yes, because it was done from 2018 to 2022, so we did include COVID, like the patients presenting during COVID.
We did attempt to see whether the COVID is influencing increased risk of mucormycosis and causing orbital apex syndrome versus the patients otherwise, and that's why we also tried to do a subgroup analysis that whether patients who are less than 40 and more than 40 are likely to have difference in the etiology. Okay. So we did find that patients with COVID, the orbital apex syndrome was more likely due to mucormycosis.
Definitely fungal etiology is definitely not that easy to get a good result. Other than that, in your series, what is the commonest cause that has affected the orbital apex syndrome, and what was the visual outcome? What was the cause which is given you the best visual outcome? What was the cause which is given the worst, other than the mucormycosis?
The ones which were diagnosed as Tolosa-Hunt syndrome, they received IVMP and oral steroids. They had better visual prognosis compared to the fungal etiology or IgG4 disease.
Fungal etiology, leave it. That itself is a problem. Other than that, what are the observation? Because that gives you a sort of an idea to the student that this is the problem which we have to treat to get the good results.
Chronic granulomatous inflammation, either presumed due to tuberculosis or those with Tolosa-Hunt syndrome had a best outcome.
You mentioned ENT procedures. What are the commonest ENT procedures you faced with this orbital apex syndrome?
Actually, during COVID time, some of the patients, they underwent diagnostic nasal endoscopy and biopsy. Thank you.
Thank you. Thank you.
So next we have Dr.